Mastering cardiac auscultation requires moving beyond simply identifying S1 and S2 to interpreting the timing, quality, and hemodynamic responses of complex sounds. This guide focuses on the clinical differentiation of advanced auscultatory findings. Differentiating extra heart sounds S3 versus S4 and snaps. S3, also known as ventricular gallop, occurs in early diastole, rapid filling phase. It's a low-pitched sound best heard with the bell of the stethoscope. It's associated with volume overload, heart failure, that is systolic dysfunction, or high output states. May be heard in normal young children. S4 or atrial gallop is a late systolic event due to the atrial kick. It is also low-pitched and heard best with bell of the stethoscope. It is associated with stiff hypertrophic ventricles, as in aortic stenosis, hypertension, and hypertrophic obstructive cardiomyopathy. It is never heard in atrial fibrillation because of lack of atrial contraction. Opening snap is an early diastolic event occurring after S2, high-pitched event heard best with diaphragm of the stethoscope. A shorter S2-OS interval indicates more severe stenosis in mitral stenosis. That is due to higher left atrial pressure. Pericardial knock occurs in early diastole. It's a high-pitched sound. Occurs in constrictive pericarditis earlier and is sharper than S3. Represents the sudden cessation of ventricular filling. The shape of murmur on a phonocardiogram reflects the pressure gradient across the wall. Crescendo, decrescendo ejection murmurs typical of aortic stenosis. The later the peak of the murmur, the more severe the stenosis, as it takes longer for the ventricle to generate peak pressure against the narrowed orifice. Hollow systolic, characteristic of mitral regurgitation or ventricular septal defect. The pressure gradient between the left ventricle and left atrium remains high throughout the entire systolic phase in mitral regurgitation. Decrescendo, regurgitant murmur, typical of aortic regurgitation. It begins immediately after S2 and fades as the pressure in the aorta drops and the LV fills. Dynamic auscultation. Physical maneuvers are essential when two murmurs sound similar, as in aortic stenosis versus hypertrophic obstructive cardiomyopathy or MR versus TR. Preload and afterload maneuvers. Valsalva strain phase decreases preload, decreases most murmurs, aortic stenosis and mitral regurgitation. Increases the murmur of hypertrophic obstructive cardiomyopathy because smaller left ventricular volume allows more obstruction and moves the mitral valve prolapse click earlier. Squatting increases both preload and afterload. Increases AR, MR and AS murmurs, but decreases HOCM murmur and moves the MVP click later. Hand grip increases afterload or peripheral resistance. It increases left-sided regurgitant murmurs like MR and AR, but decreases the murmur of aortic stenosis and HOCM. Respiratory maneuver, Cavallo sign. Inspiration increases right-sided murmurs like TR and pulmonary stenosis due to increased venous return. Expiration accentuates left-sided murmurs like MR, AR and AS. Gallavardin phenomenon. In elderly patients with calcific aortic stenosis, the harsh systolic murmur may be heard as a high-pitched musical sound at the apex, mimicking mitral regurgitation. Differentiate using hand grip. MR increases, AS does not. Austin Flynn murmur, a mid-diastolic rumble at the apex heard in severe aortic regurgitation. It is caused by the AR jet displacing the mitral valve leaflet, creating a functional mitral stenosis. Summation gallop. When a patient has both S3 and S4, usually during tachycardia, the sounds fuse into one loud diastolic sound. Always palpate the carotid pulse while auscultating. Murmurs occurring with the upstroke are systolic. Those occurring after the peak are diastolic.